Michael Krausz. Very good. And I'm a German Canadian. I'm living nearly 18 years in Canada. I'm the leadership chair for addiction research and the current president or the founding president of the Canadian Academy of Addiction Psychiatry. And I thought, and so I heard that all of you are med students, and I wanted to surprise you a little bit, not just talking about pharmacology and different drugs and all that, but more a little bit a holistic picture. I want to also bring in a different perspective to the whole story. And actually, really, I want to share with you what I think needs to be done and what kind of areas are, let's say, need to change, need to radically need to adapt. I would say the current opioid overdose crisis is changing nearly everything in the area of addiction. I want to explain a little bit why. And I will also share some videos with you. This is a longer presentation, but it doesn't matter because I think it's really nicely structured so that you're not getting lost. Can we share the screen or can I share my slides?
Yes, I think you should be able to share.
Okay, beautiful. Okay, let's go there. And if you have questions, don't be shy. We can move that. So I have to move my slides. I have so many screens here. Do you see the?
Yes, do you want to maximize the view? I think it should be over, I think it's the green button on the top left.
Yeah,
Yeah,
yeah, okay.
let's see if that works.
Green button on the left. This meeting is being recorded. Okay. And so what do you see right now? Do you see the slide?
I see slide, I think 5 or 6 in the PowerPoint presentation itself. She's referring to the green button it goes red, yellow, green, and it's above the title slide in the sidebar.
It is not PowerPoint. Okay.
I think this view should be good if you want to just click the first slide and start from there.
Yeah, I will move that by hand. And this is a video. And I want to, let's check whether you can hear that. So this is a direct view into the emergency room. And that was is a patient which was seen in a very desperate situation in our emergency room.
You
hear that?
My name is Wayne Cody Brown.
Are you okay if I use this interview for teaching purposes?
Yeah, that's okay.
So I'll just share it with medical students, residents, stuff like that. I might show it at a medical conference.
That's fine.
I might put it on. Would you be okay if I put it on social media? Would you rather YouTube or not?
It's okay.
I can share it with you when it's. If you don't like it, I don't have to use it.
Okay.
If you ever want me to take it down, you just have to let me know. I'll take it down.
Okay, this is what we need to say. Recording.
You should know that I'll treat you whether you consent to this or not, although I've already treated you. Okay, so you've had how many overdoses in the past 6 days?
Oh God, 3.
3 overdoses. And you've been on Suboxone in the past?
I have, yes.
And did it work for you?
It did work for me, yeah. Yeah.
How long were you abstinent on it?
About 6 months.
And the last time you were here, they tried to microdose you onto Suboxone.
Yeah, they
in
did.
the emergency department.
Yeah.
And that didn't work.
No, it didn't. You know, they say that Suboxone blocks the opioid receptors in your body and that you can't get high. But that's a lie. You can still get high if you smoke enough, because the stuff they're putting in the heroin today, it's mostly fentanyl, benzos, and now tranq. So like Lam, for instance.
That's right, yeah.
Yeah.
So you had to do something different because you've now had 3 overdoses in 6 days. So we just did what we're calling direct sublocade, where we just gave you the injection directly
That's right.
without trying to microdose you in the first place.
That's right.
How do you feel?
I mean, I feel like I feel better. I feel better with the fentanyl.
Yeah.
And the pain, like there was no pain this time.
That's right, because we also did something different where we gave you lidocaine first.
Yeah, usually they just ice it.
Yeah.
And the ice, I mean, it helps a bit, but it hurts like hell.
And
Especially the 300 milligrams.
And how much pain did you have this time?
Zero.
Zero pain. That's pretty cool. Was that the first time you had zero pain?
That's the very first time.
It's pretty cool.
I'm gonna tell people.
Yeah. All right. So, okay, so now you're on sublocade.
Yep.
What's the plan?
Well, I just had my first son 4 days ago.
Amazing.
It is amazing. It is amazing. And plan is to clean this over for good.
Good man. Okay.
If not for me, it's for my family.
Well, you got it. You have a little kid now.
I know, I have 2 people relying on me.
Well, you were able to do it before on sublocade, so now you're on it.
Yeah, I don't see why not.
Good work.
Thank you.
Just stay in touch, huh?
I
Okay. Did you ever had a conversation like that? Yes?
Yep.
So I could do I could talk about that for a full hour, because I find it has so many components which you can uncover there and could sort of, and look, I'm always still, despite my age and whatever, I'm still touched by all these situations, because probably the majority of these patients like him will be just sent home with no big treatment. So in emergency rooms, I'm pretty sure that's also similar in the US, the kind of traffic in, traffic out. So no long discussions, no long conversation, no counseling, they're not taken serious, despite the fact that this person was probably 3 times at risk to die of an overdose, because we don't know what he took and we don't know what the circumstances were. But 3 times a week an overdose, is a little bit, it sounds a little bit also suicidal, at least severely self-harming. And then when he answered, he said, okay, I just became a father and I want to stop and change everything, but not for me, but for my family, which also is a message. So he's not really that, let's say, thinking about himself and his life and what he needs to do to be a father. So I think what that also kind of shows is that he needs a lot of different ways of support, and which we are not providing, not in Canada and not in the US. So, I mean, for instance, I think he doesn't have this, not even a small chance to discontinue his current trajectory without, for instance, involving his family in the treatment. So so what I want to kick off a little bit, to think beyond just the immediate medical condition, or let's say physical condition, but think beyond that. Because what it also means, if he really is serious and he wants to take care of his kid, it will be an enormous, different kind of stressful life for him, where he may fail and he needs support. Actually, what that reminds me also that in the US, for instance, in our analysis of administrative data I think it was in Yale, they found that less than 10% of the kids, the adolescents surviving an overdose, got any kind of purposeful treatment, just were sent home. And there's a second point I want to make. So this young man, who I think is very sympathetic and kind of, I think you wouldn't think about him living in such or being in such a desperate situation. He is self in need, but if you also think that also his kids and whatever would only be able to function and to learn what they need to learn with additional support. It is not possible to do all of that by yourself. So what I want to say, look, if we want to, from a healthcare perspective, want to treat these patients and help them in this crisis situation, we need to provide, I think, a totally different set of services. We need to have, let's say, connect them with their families. We need to provide them support together, need to check the housing situation because they have a child to take care of. And you need also a medication which is kind of protected. So he got buprenorphine depot, which is, it's protective for a month, and it helps not to rush into withdrawal, but it is not a cure. It's not it's not going beyond a month. So you need to decide in that time what you want to do in terms of other kinds of treatment settings. Okay, so I think so what's the most important thing from my perspective in your age and your race, you really need to think about a holistic way of approaching patient. That would be the same thing if you have all of a sudden somebody dying in an emergency room. I think a physician who's walking away then and thinks he has better things to do is, for me, unacceptable. That's unethical. And if you don't provide treatment to somebody, so essential treatment to somebody, and think beyond just calming down certain or withdrawal symptoms, that's not sufficient. That's not a holistic medicine. That is not helping him beyond the next few hours. Okay, so this is my first take-home message there. And so let me show you also, because this is something you probably don't see that often. Let me show you another video, which is, so you will see. There's also, the topic here is also family and totally lost kid, a 16-year-old boy, also in an emergency room.
I'm Joseph.
Yeah.
So we talked about people in your life in terms of, basically, it sounds like all of your friends use fentanyl.
Yeah.
What about your parents?
My parents, my mother, she uses more than I do at the moment. But she wants to quit, I can tell, or at least be a closeted user again. But what was it? My father, he's not really in the picture at the moment.
Mm-hmm.
I'm not really sure what he's doing, but yeah.
Where does your mom live?
She lives in the same building as I do.
In the SRO?
Yeah. I usually just go up there when I feel like using.
Do you use with her?
Yeah.
Yeah. Okay. Is your relationship with your mom in some ways based on using?
In some ways, yes, but there's also the fact that she I don't know. She says that she started using down to help get me off of it, but I'm fairly certain she's just using it the whole time and then just became an uncloseted user. Yeah, to get me not homeless. Yeah.
How does it make you feel when she says it?
I do. She does kind of, guilt trip me from time to time, and she can be kind of codependent as well.
Okay. Sounds tough, huh?
It's kind of hard to like, for example, just like leave the room and she'll be like, "Where are you going?" So yeah.
So the other question is, do you have anybody in your life that you can depend on who doesn't use?
My immediate family, but they didn't really talk to me too much.
Oh, no?
Not too much, no. Not on a day-to-day basis.
All right, man. Thank you.
Yeah.
Okay, so this looks, this is what a single room occupancy room looks like, as SRO. So if you summarize, this 16-year-old boy, who is extremely mature, I think, for his age and for his conditions, is using together with his mother. Father is gone, and they're living in a shithole, more or less. I'm sure you have similar buildings in Portland or wherever, too. I know some big shelters in the U.S. So, and this is okay. This is how it looks. How they live on the street if they don't have a SRO. Even this is a homeless youth in Vancouver. So, I also I want to share that because I think sending this boy home to an SRO where he definitely will use with his mother again and lives in a extremely traumatizing environment is, from my perspective, also unethical. This is something which should be absolutely clear that for somebody like that, you need a treatment option right away, where you can send them, where you can take care of them, where somebody can take on the responsibility. Okay, so these are two specific aspects I are really interested in how to improve, what kind of system you need to provide in order to help them to become 25 and not only 16. So the likelihood of mortality there is, well, if nothing is happening, is very high. And here in British Columbia, where we have 9 to 10 deaths every day, and also if you look on reserve First Nation, there is the number of mortality is, or the level of mortality is 5 times higher than for white people. So I just mentioned that you get a good situation. Okay, let me jump to another picture. So my intention is we are, let's say, not working continuously, but I want to pique your interest in some specific areas. So, and I'm successful if you still think about some of these things after our 1 hour together here. So I want to show you, so this is the aspect of family, comprehensive, let's say, include the environment, living condition, and always have in mind, for instance, if you meet an intravenous drug user, 2/3 of them report about early childhood trauma. 2/3, imagine. I think immediately, if you talk to somebody like that, you need to be alert and you need to be aware of that they are severely traumatized already in their young years. And I think trauma is something physicians and especially psychiatrists should really know by heart and figure out how to go there. And they never get the proper training for that. Or very rarely, let's say. Okay, next chapter. To understand how the system. So I wrote a paper on the overdose crisis because that's I think a very good journal. And so what I tried to demonstrate here is the correlation between availability of OAT treatment, means so substitution treatment, and the risk of overdose, and to see that how important that is. So the blue bubbles are high rates of opiate overdose. The orange ones are moderate rates of opiate overdose, and the gray ones are low rates of opiate overdose. This is the x-axis is the average number of OAT recipients per 100,000 users. So you see, it's very it's a large variety, and this is something which turned out not to be so important. That's the harm reduction measures. So safe injection and syringe exchange doesn't have really any impact on the overdose rate. So okay, and these are different countries, and I know very well what's happening in the different countries. I can tell you also why the Baltic states, the US especially, and Canada are top of notch in terms of number of overdose. So Valentina, what do you see here on this beautiful handmade graph?
Well, I think that there's a lot of historical context, especially to the Baltic states, Estonia, Lithuania. They have similar histories within the recent regimes that have taken place between the 80s and the 90s that I think it's laid out the context for certain legislation to be in place that unfortunately is also reflective in the United States. I want to contrast those attitudes with those of the Netherlands, where you're seeing in here there's a lower rate of opioid overdose. I would suspect that because there is also a higher needle syringe distribution happening in the Netherlands, there's also other harm reduction modalities in place, which would be in contrast to the United States.
Right.
I don't know where everyone else is on this call, but I'm originally from Romania and I'm currently in Eastern North Carolina. And right now in North Carolina in general, syringe exchange is illegal. And we did try to get something passed within the legislature at the state level 7 years ago. That was something that I was a part of. Unfortunately, the legislature approved it, but only if the organizations labeled their syringes, which just was completely unaffordable. But that's an example of how loopholes legislatures try to create to make it seem like they're doing some good when they really are opposing it to begin with. So that's what I'm seeing here. I'm seeing a difference in historical context, cultural attitudes, manifestations of ways that legislation impacts healthcare delivery. Because I think in terms of the healthcare models, the countries are very similar except for the US. You have mixed models, socialized healthcare with some private opportunities.
Yeah, but this is already good. I think there are two things you can learn here, but I will say a few things. Are there any other comments or any other wisdom anybody else has to share? So our male participants are hiding. Are they so ugly, or what's the reason?
I was gonna say that if you look at the x-axis, it looks like so the average number of people receiving actual, medical treatment for their opioid use disorder, like, buprenorphine or methadone, it's like nearing 240 per whatever for the Netherlands. And I think that's also playing into it, is that there's more people actually getting, pharmacologic treatment for their use disorders, and those places have lower overdose.
Yes. So if you would, so you're correct. For instance, Valentina, the spots on this graph are related also, or they're based on different systems of care. That's correct. So so I would say the US and also Canada to a large degree don't have a comprehensive system of care. If you compare let's say especially Switzerland and the Netherlands and Austria with the rest, they have a really well-functioning system. For instance, in Austria, they say they have a very high coverage of OD treatment. For instance, the US had at that time probably between 13 and 15% of all intravenous drug use were in OD treatment, which is kind of nothing. And there was a retention rate in the treatment, which is a nice reflection of the quality of care, of probably a few months, 3 to 6 months, and then they dropping out. And that all contributes to a higher risk, because OD treatment, for instance, is also leading to a higher opioid tolerance, which means even if you use fentanyl or something else, the likelihood of experiencing an overdose is not that high. So this is why. I think the treatment system is changing things. The point which is kind of also very important there, as a second point I want to mention, that is the dynamic of drug markets, which is also very different. Also, I published a nice paper about that. I don't know whether I sent those papers to Priscilla. If not, remind me. For instance, what you said, the Baltic states, but also Ukraine, Russia, Romania, Bulgaria have a very ignorant approach to drug use. They have had always the highest HIV rates in the 90s and 20s, which I was in Ukraine, for instance, I think in the end of the 90s, and they had nearly no treatment system for them, and they had specific patterns of use which were especially dangerous beyond opiates, and they also the drug market. So the providers of substances were different. So as the Baltic state got from Russia at that point in time China white, which is including fentanyl. So it's also what I want to say. It's the number of overdoses is also always a reflection of the patterns of use and of drug markets. So unfortunately, most physicians are not really, let's say, aware of other social determinants of health and things like cultural context or drug market, which is a significant thing. So what you see, for instance, in Portland and in Philadelphia and in other places, also in Seattle, is a second wave of changing patterns of use, which is connected to trank dope. Everybody knows what that is? Yes? Did you see patients already with trank dope?
Yes. I work as a registered nurse. I'm a fourth year medical student, but I'm also a registered nurse and I do wound care. And we've been getting a lot of patients coming in with trank wounds. And we're starting to also see women specifically that may be pregnant that are starting to get trank wounds on the breast, because breasts tend to be an injection site for pregnant women. And so we
Yes.
didn't think originally that tranq did central ulcerations, but I've done some wound care on some breasts, so I'm not really sure what's going on there.
Yeah, that has to do with the pharmacology, but I don't want to dive into that. But is the point you need to understand is also from what I said, you need to understand the patterns of use, and so a very important learning is where I hope you think about too afterwards is that every behavior has its functionality, whether you like it or not. And a good therapist, a good physician thinks, okay, what is the benefit for somebody to destroy himself and his body in this way, as this picture showing, and taking another risk on top of high potent opiates. So Tranquil leads to the injection of this veterinarian benzodiazepine, which has no indication for humans, is that it extending the bioavailability of fentanyl and the effects for 1 or 2 hours, but it's leading also to necrotic changes in your fasciitis. So it is absolutely mind-boggling to see these people on the streets, and they don't go to a hospital. And what they do, I don't know whether you heard that, if they have really a kind of starting sepsis or anything, they even, because they don't have the money for a proper surgery, they cut off their own arms if so. You have things like in barbarism, like in the most awful situation you can imagine. And so what I want to say with that, if you don't understand the dynamic of the environment and the drug markets and living conditions of these patients, you can't really provide a proper system of care. And yeah, I know, and I think that's really fantastic that you're providing first aid on the street, but in the end, these people need. So I think these people need to be in an inpatient facility, need to be probably comprehensively treated, need to be convinced that they should stop to use this kind of combo. And some are aware of that, but most of them are very helpless. They don't know what to do, and they don't know how to get rid of that because it has all of that has awful withdrawal symptoms, and that's something you always need to understand. If somebody like this is coming to an hospital, and it takes 3 hours, more or less, give or take, until they push into withdrawal. And withdrawal from high potent opiates is awful. It's painful. So you will not be able to convince them to stay in the hospital, even if they need to get immediate attention.
Valentina, I saw that you had your hand raised. If
I just had a quick question. One of the things that I think I struggle with is a lot of these individuals may want to quit and they may have the desire to quit. But with xylazine coming on the market and medotimidine coming on the market, that one's a little bit newer. They just don't know what's in their supply, so they could very well be wanting fentanyl. At least here in North Carolina, we haven't seen heroin, pure heroin, in a very long time. So they may be wanting other substances, but everything's getting cut and dirty, and I mean, they maybe even want meth, and what they're getting is meth cut with xylazine, which gives you a whole different high. What do you, I mean, we haven't seen this, have we? What's your experience historically with the evolving drug markets and people wanting a substance and wanting to get off this substance, but
Look, it's a very good question. I think as clinicians sitting in the same room with somebody like this guy, but also as people who have influence to a certain degree on the healthcare system development and what kind of services you want and you need. You actually, first of all, you need to be aware what's happening and what's coming your way. And second, you need to develop services in a structural way which are able to cope with that. And our services nowadays aren't. They are kind of all of it are first aid. Even in an emergency room, you probably, even if you see somebody and talk to them and are well intended, so you don't have anything to send people to. You have very little to offer them, and that leads me to the second one, to the intervention. The intervention for such a person like him here are very complex. You need to figure out. First of all, we need to stabilize them in order to do acute treatment, and probably he needs surgery. He needs surgery. He is otherwise he's getting septic, and he dies of the sepsis. I hope you all know what that means, and he needs antibiotics, and he needs a bed, and he needs stability in order to survive. Otherwise, not a big chance to survive. So what I'm saying is, in order to cope with a public health crisis like that, you need to think about how to adapt existing protocols so that you are able to effectively deal with the patients, which means first and foremost, stop their withdrawal, and second, stabilize them in order and protect them for at least for a while to deal with the physical or the mental concurrent conditions. None of these patients are otherwise mentally stable or healthy. They are, and also not physically healthy. So second thing I want to mention also, 2/3 of the opiate users are actually reporting chronic pain. 2/3. So imagine, put it together. 2/3 with early childhood trauma, 2/3 with chronic pain, and I believe my patients if they're telling me that. So I think it must be a problem. It must be a core motivation. And if you don't treat pain appropriately, then or if say, okay, I gave you 4 weeks or for 2 months opiates as a primary care physician, and now you have to survive otherwise. Where do people go, for heaven's sake? They go to the black market. And Valentina, there was never something like pure heroin. That was never. Heroin was always, and you probably don't know that, was always probably 10 to 20% heroin and 80% contaminants of all kinds.
like adulterants that prolong the high or just contaminants?
Oh no, just to sell more. It's just business.
Yeah.
And the whole shift in the drug scene is that they not sell what they promise to sell, is that they want to make more money, and they're diluting things. And nowadays what will happen probably in North America as well as in other parts of the world, that the opiates are more diluted or even the stimulants with a little bit of fentanyl, with a little bit of other stuff to get them, let's say, to save the customer, let's say it that way, and which is increasing the risk spiral. And I will kind of show you another picture. This is No, I just want to show you another thing which is important to keep in mind is this one. I think most people probably don't know, but 70% of the fentanyl users are inhaling, which say, oh, for heaven's sake, that is great. The problem is also with the inhaling, a highly potent opiate, it's nearly impossible to dose because you don't really know how to what's kind of define the amount of substance you need and you want. So they are inhaling all day, which is also a challenge because how do you want to provide appropriate treatment? So it's very complicated. How do you dose then, and with what kind of oat medication are you using for that? So it is, that is a very long additional discussion. That's what I meant is you need to adapt protocols. So you can't just distributing a little bit of buprenorphine or methadone, that is better than nothing, but it's not really resolving and addressing the needs of these patients. And what you need beyond that, you need to deal with all the physical and the mental conditions. So back to the beginning, I said that everything has a functionality. Whereas if somebody is severely traumatized and has nightmares, is not sleeping, is really suffering from all these experiences. By the way, did you ever meet somebody who was traumatized, and did you talk with somebody who about his traumatic experiences?
Yeah, definitely a lot.
Yeah. Is that something you learn also in med school, or you're discussing trauma treatment?
I think it is more so. We definitely talked a good bit about the ACEs, like the adverse childhood events. I don't know how much we talked about trauma in the context of addiction, but I definitely think it is starting to be more so integrated in medical education than it was historically.
You don't understand addiction if you don't understand trauma. But I want to say mainly the point is you need to understand why people are doing what they're doing. If you don't understand that, then you can develop an appropriate treatment. It's not just whether you give them one pill or two pills. It is the question: what do you want to achieve, and how do you protect them, more or less? Ryan, what do you think? You look so in deep thoughts with your big ear heads there.
I'm just trying to, I'm a first year student, so I'm just trying to absorb everything and take notes. um,
Which city are you from?
I'm originally from Philadelphia, but I'm doing medical school in Yakima, Washington, on the West Coast.
Philadelphia is a hotspot in the US, is it correct?
Yeah, that's right. A lot of the stuff you see on social media and the internet is about 5 minutes from where I live for about 4 years. So, I I had a little bit of experience just in the community of like helping clean up a lot of the garbage and needles in the streets, but I never really had any clinical experience yet. So now that I'm in school, I'm trying to learn more and take a more clinical role in the community.
Yeah, I think what Valentina is doing, that she is, let's say, doing a little bit first aid or volunteer work on the street, or even probably professional work as a nurse. By the way, that's a good way to start a medical career. I'm a registered nurse myself.
I love that for us. It really is. I think everybody should be a nurse before a medical professional. Absolutely.
Or change medical school, because you learn much more about practical medicine in the nursing training than in med school. In med school, you barely be able to know how which end put in the needle into the body and so on.
That's absolutely true.
Okay. Um, I think so. Let's say I stopped my little exposure therapy here, and what I think is a recommendation. If you are consider, let's say, diving a little bit more into that area. But I really think so. Beside being really on the street and in an emergency room and having a look what's going on, you get a really good comprehensive picture of what's needed. But what I highly recommend, um, also compare different countries and just don't think the US is kind of I think is the green light hit there, or is really where everything needs to go. I think that's in healthcare it's the opposite, and I would really um, recommend for every direction you want to go into, consider spending some time in other countries like, for instance, Australia is a good place, or Netherlands is a good place, or and have a look how they what their attitude is, and you can learn so much for medical ethics and for also very practical approaches. So you can study functional systems, which the US is not a functional system. Canada is also not a functional system. There's so much stigma, so big gaps in the system of care, and also a lot of things you never really learn in med school. So then you need to learn it somewhere else. I really learned a lot from traveling to low-income countries, especially, and to other parts of the world. So there are lots of very rich countries which are unable to provide a proper care and something to a condition which is causing the US already a declining life expectancy. And it is a crisis which is there for over 10 years now, and there is no land in sight, I would say, and it's getting more complicated. So yeah, so I used obviously also some clinical examples from Vancouver. It's not much better because there is no system approach. But anyhow, I sent a little bit of literature. If you're interested in that, I'm sure Priscilla is so kind to share it and have a look. And then if you want some time, a follow-up, or whether you want to visit some of our beautiful conferences here for the Canadian Academy for Addiction Psychiatry, you're welcome always in Vancouver. And yeah, to learn also from our mistakes and make it better than we are doing that right now. So I think, any questions left, or are you now going to bed depressed and need to drink a good glass of beer or something like that to fall asleep?
I have a question I don't know if you have the answer to or not.
I will tell
Thank
you.
you. Thank you for the talk, by the way. It was extremely interesting. As somebody who's actually not in the psych side of things, but going into anesthesia, um, I was not aware that medetomidine was such a common adulterant now. And that's interesting to me because dexmedetomidine, the right-handed enantiomer, is used all the time in anesthesia, in the form of Precedex, um, as like an adjunct analgesic and sedative. But I'm really curious whether medetomidine on the street is being imported from somewhere, or if it's diverted from legitimate healthcare sources, or if we have any idea.
Both.
Mm.
It's both. You can I think you probably using computer and so, and you probably heard also from the darknet. I don't know whether you ever used it. Also something you should try. You can buy everything there, everything, yeah, a lot of my colleagues in the U.S. building their whole explanation and their model of the current overdose crisis on the misuse of prescription drugs, which is it's if you dive into that, even as a future anesthesiologist, you will be surprised that, for instance, the U.S. is or the U.S. physicians prescribing the highest level of morphine equivalence in the treatment of pain, I assume mostly. But Germany, my home country, is prescribing or using nearly as much per capita. You have a enormous overdose crisis in the US, I said, with a declining life expectancy. And in Germany, nothing. So, which is gives you some thought for also some food for thought, I would say. And I think that gives us a hint that the way we organize pain treatment is not very smart. So we call it a little bit, if you look at it in a more sophisticated way, we call it opiate stewardship. And it's not really happening that much. So, and that putting people at risk. So I agree with that part. I don't think it's an explanation for the current opiate overdose crisis. And what I would really wish from my colleagues in emergency medicine and anesthesiology, they should know well how to deal with opiates, but they don't. They are kind of very, I think to a large degree, very helpless. So for instance, what do you do if someone with a high dose of fentanyl is coming to your emergency room with a whatever severe physical health issue? How do you make sure that they are not crushing into withdrawal and leaving the necessary hospital bed and whatever? They don't know. They don't know. They also inject because they read that somewhere naltrexone and increasing then they think, okay, this is dangerous, so we need to protect them, and they crush people into withdrawal, and then they say, oh, they don't know, and then they're leaving, and then they blame the patients. So it's kind of I hope really that you, as the next generation, doing better than the established ones. And if you have let's see, a basic understanding of how opiates are working, you should do better than that. Okay, I leave it at that. I need to run to my next place. It was a pleasure to talk to you. And
Thank you so much.
Yeah, thank you so much.
Thank you.
take good care and continue your good work.